So I just want to say thank you to Josh for inviting me along, and he sort of gave me, he wanted me to try and inspire the next generation, I suppose, and just sort of tell people about my story, about how I managed to get to where I'm at. So I wanted to thank Josh for inviting me, and also thank you, Joe, for the kind introduction. So I think my story is sort of interesting because I've had a few challenges along the way to get to where I'm at. So my background is that I am a white Anglo-Saxon middle-aged man. I'm losing my hair, I admit. I was born and raised in South Australia. I have 2 children, married, and I live in the eastern suburbs. So I probably fit a specific type of demographic for this type of role that I'm in. However, I don't come from a medical background. My father was a teacher and my mother was just a homemaker. And prior to that, all of my family were sort of from farming backgrounds, from rural centres. And these are my current roles. So I'm a general surgeon, and I subspecialised in trauma and emergency surgery. And I did that some time ago because I'll go into it in a little more detail in a bit, but that was where my interest lay. And in 2021, I became a medical lead in the surgical program. And I'm one of 3 medical leads, and one of my co-medical leads is sitting here and will also be presenting to us shortly. And across surgery, across both Queen Elizabeth and the Royal Adelaide Hospital, we have probably close to 30, or actually over 30 surgical units. And I currently oversee quite a few of them: orthopaedics, plastics, ENT, craniofacial, burns, spine, dermatology. And we have dual units across both sites. Prior to that, I was the head of the trauma surgery unit and the acute surgical unit here at the Royal Adelaide Hospital, and I was in that role for about 6 years. I also look after some rural surgery services, particularly Port Augusta and Whyalla, and Joe has worked with me in both of those places, as has Josh, and I've also been involved with Port Lincoln as well. I'm also currently the chair of the South Australian and Northern Territory Training Committee of the Board of General Surgery. So that oversees general surgical training in South Australia and Northern Territory. And I'm also a member of the National Board. And last year I became a clinical associate professor of the university here as well. So they're my current roles. Having said that, so I work for Karl, but this is what the leadership in Karl actually is. So we all report to someone, and overall, the boss of Karl is Leslie Dwyer, or it is until tomorrow, I think, isn't it? Yeah, next week. So she will be leaving us fairly soon. But even she has to report to the governing board of the hospital, which is led by Raymond Spencer. She also has to report to the Minister for Health, and she also reports to the CEO of SA Health, who is Robin Lawrence. And you can see that to the right of that, or to the left of that, sorry, is the Clinical Council, and Peter sits on the Clinical Council. So, and you, below all of that, you see all the executive that is within Karl. Now, this is the program model. So this is where everyone sits in the grand mix. So I'm actually towards the top left corner, medical lead surgery 1. So you can see surgery sort of has 3 streams there. And there is also a medical lead for surgery 2. There is a medical lead for surgery 3. So we've divided up all of those units across those 3 programs. But I don't look after surgery all on my own. We also have nurse leads across those 3 sites, and we had allied health leads. And sort of the person who tries to pull this all together is what we call a program director. And we have a new program director who's come over from the UK recently, named Bernard Johnson. And our leadership really is what we call a distributed leadership, where everyone has their own roles and reporting lines, and we try to make decisions as a team for to get surgery working. So, how did I get to this point? Well, a long time ago, I was a medical student, probably like you guys here, and I went to the University of Adelaide, and I will be honest, I was an absolutely terrible student. I failed my first year of uni badly. I then failed my second year of uni, not terribly well either. And at that point, I realised that something was not going right. The problem I had is that I didn't have a lot of money. I didn't have a lot of support because I didn't come from a background that really knew a lot about this type of thing. I was sort of lacking direction. I think probably what I really did is I discovered the uni bar, and I discovered that girls are actually quite an interesting thing. So I took a year off, which I think was 1994, and I worked in that building there, which was a hotel called the Hotel Adelaide International at that time. And that helped me sort of reset my mind and give me a bit more focus, got me used to working. And I continued to work in that hotel throughout the rest of my undergraduate degree, right up until the end of 6th year. During that time, when I got to 6th year, which was in 1999, I did a term in Mount Gambier on the general surgical unit there. And there was also some orthopaedics there as well. And I worked with a chap called Richard Strickland, who was the father of one of the intensivists here now, and another chap called Mark Landy, and a orthopaedic surgeon called Barney McCusker. And there was another orthopaedic surgeon as well, who I swear was the angriest man I'd ever met in my life, called Henry Forbes. I think he's still there and still just as angry. He's had a heart attack, but he still gets very red in the face, I believe. So that kind of sort of made me realise that this is what I wanted to do. General surgery is something of interest to me. So I did graduate, believe it or not, despite my checkered history in the university, and I did my internship in what was called NWAS. So at that time, the Queen Elizabeth Hospital was actually affiliated with the Lyell McEwen Hospital. And this is one of the little messages, is that even though we are currently Carlin, previously we were called something else, and we weren't affiliated with the Queen Elizabeth at the Royal Adelaide. So these things do move around, change around. So I did my internship there, and I got into what was called basic surgical training in 2001, and I did my first year at the Queen Elizabeth. I did ENT, orthopaedics, emergency and urology, and that was actually the first time I met Mr. Subramaniam, because I think he started as a consultant there, and he started to give us some tutorials in surgery, which was quite vascular focused, but they were still good tutorials because we didn't have anything before then. Following that, I came over to the Royal Adelaide, and I did some other surgical terms, as well as ICU and trauma. And then I spent another year at the Royal Adelaide the following year, where I did urology, and I remember you from that time, but you won't remember me. I also did some other things. But I think it was the second to last term I did, I worked in Berry Hospital. And that's when I realised that out of all the surgical specialties I'd done, and I'd actually, up until that point, had been leaning more towards orthopaedics, I realised that general surgery was really the thing for me. And also, it's interesting because in both my undergraduate year and also in my basic surgical training, it was a rural term in general surgery that made me want to do what I wanted to do. I'd completed my Part 1 exam, which was just as awful then as it is now, and it took me 2 goes, and I completed all the other components. I did the courses that you're meant to do. I had strong referees. I got good assessments on all the units I was on, even urology, Denby. But at that time, there was a surgical bottleneck, and there used to be basic surgical training, and then you would progress into advanced surgical training. And if you're the right type of person, that's the way it always appeared to us, you would progress onto advanced surgical training. But there was quite a few people ahead of me, and so I had to wait. I did a couple of service registrar years. First one was at Flinders. I should put that up there. So I was at Flinders, and then I was at the Queen Elizabeth the following year doing breast and endocrine and then upper GI. But I didn't progress. I'd applied for advanced training on 2 occasions, and at that time, even though I'd done everything, I felt as though I was on the surgical scrap heap, you know. And I realised I need to do something different to be able to progress. Because one of the things I'd like to emphasise to everyone, for all you junior guys, is that if you go into surgery, it doesn't really matter what area you go into, your surgical career doesn't actually start when you become a consultant. It actually starts at the moment that you make a commitment to go down that path. And it's just like any other profession that you go into. You don't go into law and then become a high court judge, do you? You have to work your way up. You know, you go through university and then you have to sort of have your junior lawyer, senior lawyer, etc., etc. Similarly, if you want to become a pilot, you know, and fly the big jets, you don't start in the big jets. You do all the years of training to you know, learn to fly a plane, then you do little charter flights and little planes, and then you move on to bigger planes and then bigger planes, and eventually you get to fly the big jets. Now this man, I guess most of you would know who he is. He is one of my great heroes, Martin Bruning. He became like a mentor to me because he had a similar career trajectory before me, and he sort of picked me up and dusted me off and said, you know, don't worry, Chris, we will look after you. And he'd actually recommended to me at that time to actually consider doing some research. And so at that time I did a Masters of Surgery, and I worked closely with this man who everyone would know who he is as well. He was actually very good to me, and was also like a mentor to me. And I did a Masters of Surgery. I did some animal studies looking at radiofrequency ablation, which was like a novel treatment for liver cancers. And I eventually got my degree awarded in 2008. But just prior to that, I got accepted onto what was now called the SET training program in 2007. And I was actually one of the highest ranking candidates in the country at that time. Primarily because I was doing the research, which was not something that everyone was routinely doing at that time. And my first year actually deferred so I could complete my research. I actually contemplated doing a PhD like you, Josh, but well, I wasn't married at the time, but my wife definitely would have kicked me out if I was to go down that path, so 2 years was more than enough. So I became a surgical registrar. I was on the training program, and I did that in South Australia and Northern Territory, and that all went well. During that time I got married as well, and my first son, who's giving me a lot of grief at the moment, but he was born halfway between the written exams and the Viva exams. He actually was preemie because he was meant to be born after the Viva exams, so it was all meant to be perfect. Of course, life is not perfect. And I realised at that time that subspecialty training was not going to be for me, because all of a sudden I had a family, and I really needed to settle down and actually start thinking about them. And it was around this time that General Surgeons Australia had put out this 12-point plan about emergency general surgery. And this was something that really struck a chord with me, because I was always interested in general surgery, and I'd become interested in emergency surgery. And I thought, this is where I'd like to be able to sort of really focusing my future efforts. And the nice thing is, I didn't need to do additional post-fellowship training to be able to do this kind of stuff. And around that time, the acute surgical unit had started up at the Royal Adelaide as well, and they were trying to grow that. And the other thing that I thought, at least for the Royal Adelaide being a major trauma centre, they were also looking for a trauma fellow, and emergency surgery and trauma kind of go quite nicely together, I thought. So in 2012, I was doing this kind of thing, which is probably the most exciting sort of year of my career, sort of, you know, doing some really exciting stuff, life-saving stuff. And that, believe it or not, this guy actually survived. And then the following year, in 2013, I became a consultant working at the Royal Adelaide, and I was working on the acute surgical unit, doing trauma as well. And I also, thanks to Professor Maddern, got on the rural surgical roster, so I started travelling to Port Augusta every 5 weeks a year. I was also interested in surgical training, so I got involved in a lot of surgical training issues as well. So in 2015, there was something called Transforming Health came out. And that was, the crux of that is that there was going to be an amalgamation of services across the Queen Elizabeth and the Royal Adelaide Hospital. And as part of that, the vascular unit became one unit at the Royal Adelaide. The breast and endocrine unit moved over to the Queen Elizabeth Hospital. And at that time, we'd experimented with different models, because in the past we'd always had 4 surgical units sharing the general surgical emergency load and the trauma load. We tried a standalone ASU model. It didn't work at that time, and there was a decision that we needed to go back to having 4 surgical units. And so our unit, the trauma surgery unit, came into being. And I was put in charge of trying to get this unit up and running. So even though I'd taken a long time through medical school, and I took quite a while to get through surgical training, once I became a consultant, things actually started to speed up, and I became a head of unit after only being a consultant for 3 years. And my aim was not to be the best of anything, but my aim was actually to make this unit work. So, and more than that, I wanted to make it a great unit. And it wasn't about me, it was actually about getting a brand new clinical unit up and running and really working well. So what did I do to be able to do that? I established a formal trauma roster, because prior to that it was always pretty ad hoc. We had Peter Bouts, who's, you know, the senior trauma surgeon here. He would go on most nights, and if he wasn't on, he wasn't on, and then you just sort of ring around to see whoever you could get. I tried to get our emergency surgery processes a bit more consistent, so we got better rosters happening. I subsequently developed clinical pathways in emergency surgery, particularly for common emergency surgery conditions. So these are things like small bowel obstructions, cholecystitis, perianal disease. I didn't write that myself, but I sort of got the colorectal guys to do that for us. Mesenteric ischemia, these are just a few. I got us enrolled in the College of Surgeons initiative called the Emergency Laparotomy Audit, which is a quality improvement program to manage emergency laparotomies. And I got the unit enhanced with additional staff. So we started with 1 intern, we went to 2 interns, we had 1 RMO initially, we now got to 4 RMOs. We got a set trainee, and to get a set trainee, there's quite a few processes that you have to go through to be able to get that. And probably the last thing I did before I finished up as the head of unit is that I got a fellow position. We'd always had a fellow, accredited by the Australian and New Zealand Association of surgical trauma. So that's now a formalised trauma training fellow position. The other thing I'd done during this time is I tried to nurture all of our junior staff, our ASU registrars and our service registrars coming through, partly because that is what had been done to me by people like Martin Bruning and Guy Maddern. And we had a lot of our ASU registrars then progressed onto the surgical program, which was, great. I've always felt very proud about that. And so I became the hospital supervisor for the SET training program. I don't remember what year that was, but subsequently became the chair of the local training board. I think it was at the end of 2020. The next thing to have happened during this time is that we had a restructure within Karl from what used to be a clinical directorate model, which had 4 very large clinical directorates, into a program structure. And I eventually became a medical lead of one of the medical leads in the surgical program, and that occurred in 2021. And the reason I took this on is because I'd been the head of unit for quite a number of years, and I felt as though I'd pretty much achieved what I was going to achieve doing that role, and I was worried I was going to stagnate a bit. And I remember Mr. Subramaniam here trying to encourage me to apply for one of the roles in 2019, and I wasn't quite ready at that time, but 2021 I thought, well, maybe it's time to do that. As that was coming about, when the new program structure was being consulted on and so on, I actually got to meet with Leslie Dwyer, who was our CEO, who was instigating all of this. And I remember something that she said to me, it really stuck out in my head. And she said something, and I might be paraphrasing a little bit here, but she said to me that people like to call themselves directors of something, even though they haven't really had the training to do the job. And it's something that we often did as doctors. We like to call ourselves the director of the emergency department or the director of this, but there's not a lot of, we don't do a lot of training to be able to do that. So that kind of inspired me that I actually need to learn some tools to be able to lead effectively. So I did a medical administration course in 2019, and I've subsequently started studying a Masters of Health Administration, which is an online course through the Monash University. So that's how I eventually got to become, I guess what people would consider a surgical leader. That's kind of my career trajectory. And these are the lessons that I've learnt along the way, which I'd like to impart on you. And there's probably some others as well. The first thing is that I'm not a natural leader. I'm actually quite an introverted person, and I'm quite happy just to go home and not worry about other things. But I've kind of sort of fallen into it, and it's not so much about being the boss. It's actually about trying to provide a great clinical service. The other thing that is important is to be self-aware and develop insight. You need to learn how to read the room, because part of what leadership is you need to be able to get people to follow your direction. And you need to have the tools to be able to do that. And being self-aware, developing insight certainly helps with that. I think it's very helpful to do something that you're actually passionate about, whether it's surgery or some other specialty, because that will help you progress and it keeps you interested and so on. It's important to have a clear vision. It's important to have mentors, because there will always be stumbling blocks along the way. And certainly I've had quite a few mentors. Another mentor of mine who I've not put up here is Paul Dolan, who is well, he's retired now, but he was a senior general surgeon who looked a bit like me, only older, which was helpful. It's very important to develop relationships with colleagues. and not just within surgery. You need to sort of, I developed very good working relationships with the emergency department, the ICU department, the trauma service and everything, because I needed to be able to make the service work. I've already mentioned that your career does not start when you become a consultant. It actually starts at the moment that you actually start working in that field. It's important to continue to learn and develop the tools that you need to develop your, achieve your goals. And always try to keep moving forward, even if there are setbacks. Don't let the setbacks set you back. And it's also, you don't have to be the best to be a success. And I'm not the best trauma surgeon out there. I mean, Peter Bouts has had so much more experience than I've ever had doing trauma, and he can manage stuff that I'll never be able to manage. But that's not to say that, I can't lead a trauma surgery unit. And the other thing is that even though I'm called a medical lead, I still need to report to a number of different people, and those people need to report to different people as well. So I think this is the last thing that I was just going to mention, because there are lots of different leadership models and leadership types. There's great man leaders, which are the very old-fashioned types of leadership. There are transactional leaders, there are transformational leaders, all sorts of different type things. But within healthcare, certainly, the desirable type of leadership is something called authentic leadership, and I certainly strive to have this type of leadership. And the characteristics of this is to be genuine, be self-aware, be transparent. When you are a leader, what you are trying to do is make people follow your direction. So you need to inspire loyalty and trust. And these 5 things are sort of what is desirable in authentic leadership, and this is what I strive for. So that is all I had to say about leadership and my journey to get to where I'm at. So thank you very much for inviting me. If there's any questions, I'm happy to answer them.
I have a question.
Yes, Joe.
You put up all your roles at the start. I imagine it's difficult juggling everything. Do you ever miss being the trauma fellow and just being a clinician, or
Yep.
moved on to bigger and better challenges?
No, I do miss it. I mean, my fellowship year was probably the most fun I've ever had in medicine, because it was, because you are just purely focused on doing as much operating as you can and sort of big, complicated stuff, so that you can become competent in what you're trying to do. So I do miss that. But, I have moved on from that too. My role now is to sort of impart that to others. Yeah. Yep.
You mentioned developing tools and doing the health administration masters. What sorts of tools are you learning in that you haven't encountered so far in medicine?
Oh, there's all these management things. So the tools for leadership really is management. So leadership is up here. Management is the tools to be able to get what you need to do as a leader. And so there are things like change management, because what I can tell you about surgeons is that surgeons get into a groove and they don't change that for the rest of their careers. They will use this type of stitch for this type of indication all the time. So that's one of the things. You need to be able to change things. And the best example of change within Royal Adelaide in the last 5 years is when we changed from the directorate structure to the program structure, and to be able to get that to happen. I mean, so there's that. It's also important to, I'm learning about managing finances and economics, because that's important. We have a budget. We are over budget. We need to try and learn how to manage that. We need to learn about safety and quality, not just at the individual patient level, but as a broader system level, because we need our patients to be able to come in and move through the health system and get out the other end safely and efficiently. So there are lots of things within that are very, very helpful. Legal aspects are another thing. We don't do a lot of law in medicine, so all of those things are helpful. Yep.
I had a question about your time in Berry. I'm headed up to the Riverland for all year next year for placements in third year. I'm very excited about it. What was it about rural work that got you so inspired?
At that time, it was, so when I was in Berry, there were two surgeons there, one called John Nettlefold. He was a great old-fashioned country general surgeon. And there was another fellow who was a bit younger called Arnold, whose son became an anaesthetist. I think the thing that inspired me by those guys is that they just could do anything and everything and do it reasonably well. So we would have a list, we'd have a couple of carpal tunnels, then we'd do a lap collie, and then we'd do a big bowel resection, and then we'd do, I remember taking out a kidney up there once, Denby, believe it or not, for trauma. That was interesting. You know, there were all these really cool things that we did, and I really liked the breadth of the experience up there, and I was pretty keen at that time to continue doing rural work, and it's, you know, I can continue to do that just because it is very broad. You know, if you become a general surgeon in the Royal Adelaide here, you, by its very nature, you end up becoming quite subspecialised. You know, you become a colorectal surgeon, and then even within colorectal, for example, that has become super specialised for some of the surgeons there who would just do rectal cancer, for example. So that was the thing that inspired me. Yeah, Josh?
What are your goals for the next 10 years?
Yeah, that's a good question. So I'm hoping to remain a medical lead for 5 years. I mean, I don't know what will happen necessarily after that. Probably need some new challenges, perhaps. I don't really know. But certainly, whilst I'm a medical lead, what I'm really hoping to achieve by the time I'm done is to see some of our units improve. And the things to me that make a great surgical unit is when, you know, all their KPIs look good, so their waiting lists are well managed. They get good outcomes from their surgery. Patients don't have to wait long to be seen in clinic, etc. The other things I really like is that they are good training grounds for, you know, the next generation coming through, and I think almost all of our units at both sites are really good for training in those various areas. The other thing I really like is academic performance as well, and I like to see you know, good research coming out of those units. And probably the one I've been working on the most with that over the last 18 months is probably the spinal unit here. So the spinal unit is a unit that's gone through transition. Their previous professor of spinal surgery has had to retire, and they have been transitioning to a new head of unit, getting their staffing levels back up to a reasonable level, and they've done all of that, and now working on the academic side of things, and they're looking to get an academic surgeon in there to be able to really push the, you know, the research side of things as well as the teaching side of things. Yeah.
Another question. If a lot of us are at either medical student or JMO level, what are some things that we could do to build leadership qualities at each of those stages?
Well, I guess you need to be, I mean, everything is just like a stepwise progression. I mean, as a doctor anyway, you do have leadership roles, you know, because you would lead a clinical team around you to manage a specific patient. So, you know, you would start, I mean, if you were to embark on a surgical career, you need to sort of go through the whole surgical training business. And as part of that, you learn to be a great clinician. You know, you learn how to operate, you learn how to make clinical decisions, you learn how to do some research, you learn clinical judgment that comes with experience and time. You learn how to manage a team, you know, because you will, as you sort of rise up the ranks, you will have interns and RMOs running around behind you. You know, you need to learn how to manage those people as they come through. You need to learn how to teach, you know, when you've got the medical students coming through. Then once you get yourself to a consultant, if if you are wanting to further progress, then I would encourage anyone to sort of consider doing some sort of more formalised leadership training. And there are lots of different things you can do now. You know, there's the AFRACMA course, which is the first thing I did, which is through the College of Medical Administrators, and that sort of gives you some built-in tools to help you lead. Plus, you also need to get yourselves involved in other committees and so on within the hospital system in which you work. And you can even do this as an RMO or a registrar. You know, particularly around things like safety and quality issues or service development or what have you. So you can actually start that type of thing fairly early on, you know, and it just sort of broadens your experience and broadens your scope. Yep.
I had a question in your role as I think it was a set supervisor. Are you still in that role?
Yeah, well, I'm actually, it's not anymore because I lead this state training committee. Okay. Yeah, so I do oversee it, and I still have very much an interest, but it's kind of at a slightly higher level now.
Okay, because I think I've heard from, I suppose, some surgical service registrars in particular that getting onto programs these days sounds like it's very difficult, and people can feel much like you did, sort of left on the scrap heap. Are you hearing a lot of that on the ground? Do you think the landscape's changed significantly over the last 20 years?
Yes and no, actually. It's certainly in general surgery, which is what I'm most used to. There's a very clear structure of what you have to go through to be able to get on the training program. So there is a structured CV. So as part of that, you need to have you need to accumulate points in different things, and doing things like doing a higher degree, getting some published papers, presenting at a state or national level conference gets you points. You get points for going out to the country. So that's what Joe did, and that's helped him. It's that type of thing. Then you need referee reports. And the reality about referee reports is that if you have a good referee, they will give you full marks, you know, if they're playing the game correctly. If you pick a bad referee, they'll give you rubbish marks. It's not actually, the referee reports aren't actually a great discriminator in the selection for surgical training. The one thing that does sort of separate people out is how they perform in the interviews, because they're quite a structured interview, and it's not just about you know, who you know. They will ask you clinical scenarios and how you would deal with certain situations. And I think there's even a technical question now, isn't there? Don't they get you to sort of do some... No? They had done that in the last year.
Suturing or tying something.
Yeah, because you need to show some technical aptitude, you know, because there's no point doing surgery if you can't tie a knot. You know, it's a bit of a problem. So it's actually... And when I was going through it, I mean, it may have felt different, but part of it felt as though it was not what you knew, it was who you knew. That has changed a bit. But certainly the demand to get onto the training program now exceeds the number of positions that there are available. So it is a challenge. Yeah, I acknowledge that. All right. Thank you.